Primary osteoarthritis of the hip is quite rare in India. Most of us start hip replacement in some of the trauma conditions. So this is something we call bread and butter of Indian arthroplasty surgeons, especially the hip arthroplasty people. Now the AVN is going up, so we are getting another indication where the patient come very easily for us. So basically the talk is decided, or this discussion is decided in 4 scenarios. Scenario 1 is a fracture neck femur, which is transcervical or intracapsular fractures, either of fresh cases when we do primary arthroplasty, and the fixation failure cases when a failed fixation has to be converted to arthroplasty. Part 2 will be intertrochanteric fractures, that is IT fractures. Again, fresh cases when you do primary prosthetic replacement. So we discuss about which cases, what indication, when do we do it, and the fixation failure when things do not work out and we want to convert that into arthroplasty. So let us discuss these 4 scenarios and what are the points which we have to discuss when we deal with these cases. So the fresh fracture femur, new cases, not initially operated. We have to discuss about what implant do we select. Do we use bipolar? Do we use dual mobility? Do we use hip replacement surgery? And the 2 issues which come is dislocation and LLD. Now basically when you have a fresh fracture neck femur, the tissues are very lax. There is no fibrosis or capsular thickness as happened in an osteoarthritic patient, and hence we do the replacement surgery. The hip appears to be unstable in the beginning, and to prevent dislocation, the surgeon they tend to use a little longer head, longer neck length, and they give increased limb length discrepancy. So basically we need to discuss exactly how do we avoid that and get a neck femur fracture. So this is a patient case scenario, 72-year-old male patient, hypertensive, diabetic, community ambulator. He goes out of the house, work, fall and injury, subcapital fracture, neck femur with combination. So how do you address this patient? What will you do? What approach? Pradeep, you can start. And try to be quick because we have 4 different things to discuss within 20 minutes.
Yeah, 72, but very important, we must find out what is his pre-fall activity. Some people are very active, but 72, I think I'll go for cemented bipolar and make him walk on the same day.
Approach?
Posterior approach.
Okay. Amar?
I'll do a posterior approach, non-cemented hip with ceramic on poly.
This head size is big, so I'm happy doing a ceramic on poly. This concept that you said that we're going to lengthen him is not true anymore. So we don't expect his limb to be long. We expect to equalize his limb length.
How do you manage if on table you have put a cup and you have put a trial stem and you realize that it looks
typically we'll use hooded liners or dual mobility in all fracture neck of femurs. So we do not go by the laxity and we do not end up lengthening the length.
And how do you measure introp that, okay, I have regained the length that I want because bone is fractured. So we cannot use any...
Because there's no pathology and no fibrosis or no contract tissue, the soft tissue is very reliable and we must get 15 degrees of extension. That's my rule in a neck of femur that I've not lengthened him. I've restored his soft tissue tension.
No. How do you judge that you have got the length which you want and you don't want to go for a little longer size head?
Exactly what I'm saying. So if you lengthen him more and I'm losing my extension, that means I've lengthened the patient. I don't want to do that.
So go by soft tissue.
The soft tissue is reliable. So the end point for me is 15 degrees of extension if I get. I have not lengthened his limb and he's got his back his native soft tissue tension.
Next.
Uncemented bipolar.
Uncemented bipolar, okay.
THA. THA with a hooded cover.
Ceramic on poly, ceramic on...
I think ceramic on poly is fine.
Metal on poly.
Either way it works out how commercial works.
Yeah, the next person.
I'm doing a cemented modular bipolar.
Cemented modular bipolar. So we are 50-50 now, okay? Who's the last one? Who decides?
I don't know the physiology of the patient. Otherwise, I do dual mobility totally or bipolar.
He's a community ambulator. He goes out of the house. He has work. He's retired, obviously, but he's active. He's mobile.
Then
Nobody wants to do a dual mobility here?
Dual mobility, HR, uncemented, I do.
This was the case. This is a post-op X-ray. Ceramic on poly was done. And there is some amount of little lengthening, maybe about 5, 6, 8 millimeters. Anything you can do to avoid it? or would you bother about it? Pradeep?
Yeah, I think this neck fracture length issue is a big issue, and high offset stem can definitely help to balance and give a good soft tissue tension.
How would you have avoided it? Amar, could you have used a, say, high offset implant to reduce the laxity of a tissue, and instead of getting a length, you increase little offset, so your lesser chance or risk of getting a longer leg at the end of the surgery? Do you normally use it, or you?
Yeah, absolutely. And you know, I think you guys are perseverating too much on limb length. Right? I mean, that amount of limb lengthening, if the guy is, you know, 5, 8, 9, 10, he's not going to really notice. You know, so I wouldn't perseverate on it. Your cup looks a little, you know, neutral. So I don't know how much version you have in your socket there. That's a bigger issue for you to gain stability. So I think if you know, if that's what's concerning you on the table, but listen, I think, you know, I'm a hip surgeon. If someone comes in with a hip problem, they're going to get a hip replacement. I'm not putting in a bipolar in anybody. So, you know, I think the way to mitigate the leg length discrepancy is, yeah, to increase the offset. But if you increase the offset too much, you know, you can get other problems. So everything has to be taken into account.
Vijay is smiling, want to differ from you, right?
If you increase the offset much more than the other side, it will manifest as limb length. You know, it is three-dimensional. It's not, you know, uniplanar that you're concerned. So if I'm concerned, I'll do a dual mobility. I won't go high offset. I want to do the same offset as the other side.
Anybody else using high offset?
The
No
problem
high
with dual mobility is that it doesn't eliminate dislocation. And if they dislocate, it makes it very difficult to close reduce. Right? So that's why I don't do them. If I have a dislocation, patient goes to an ER, they get close reduced, and I see them a week later or 2 weeks later. If they can't close reduce it, that's a problem for me now.
Okay. A second patient, 52-year-old female school teacher, younger patient, very active, no comorbidities. What will you do? Again, quick now.
Yeah, this is a straightforward total hip replacement, cementless. If the head size is small, then you can select dual mobility.
Anybody differs? Everybody for total hip? Ceramic on poly, I presume? Nobody for ceramic on ceramic? How many dual mobility people? 3 of them, okay? So,
Depending on socket size, yeah.
this was done, and we had increased slightly the offset, and there was little lengthening, 6 millimeter, again, not too big. Usually, many times you have got a little tight abductors if you increase the offset, and that can give some amount of abductor apparent deformity which gets corrected over the next 3-4 months. So the X-ray taken, the obliquity of the pelvis is gone, and limb length is much more accurate. So the patient do not have to be worried about it. You have to assure the patient that patient get adapted to few millimeter plus or minus. So,
Yeah, but you have to be careful here too, because you did get away with this one, but you increase the offset and the leg length, and that runs the risk of getting a significant functional leg length discrepancy.
okay. In which patient you use hemi replacement? If there is a TC fracture neck femur. Do you have any cutoff point, or you never use it no matter what may be the patient's age?
I think 80 plus.
They have a lot of comorbids, and we think that, you know, their longevity is very short. Then we certainly would use a bipolar. So much more smaller surgery for the patient. The metabolic insult is smaller. We'd like to keep that as simple as possible.
That's true. The people who get hemi are usually or should be biologically old, meaning having multiple comorbidities. The life expectancy should not be more than 8 to 10 years. It should be only household ambulatory. Even at that age, if they are very active, then you shouldn't give them bipolar because it's not a very good function. And if they may have neurological conditions like, you know, Parkinson's disease or some dementia and other things, you may want to use a large ball implant, and anyway, they won't be very active. So a lot of articles have been published saying that THR has a better function, lesser morbidity, longer survival, lesser complication compared to hemi. And even the evidence-based clinical practice guideline from 2021 from AAOS have mentioned that in unstable femoral neck fractures, arthroplasty versus fixation, arthroplasty always works very well. It's a strong recommendation. And in arthroplasty, to select between total hip and hemi, they are favored in terms of total hip, provided you select the patient properly. A Scandinavian country used to fix all these neck femur fractures. That was the initial dictum, but now they also are changing, and the population-based study on the Scandinavian registry have mentioned that there is almost 1 in 3 patients who are fixed. They eventually require reoperation, and 1 in 7 were converted to THA. So basically, they have recommended that surgeon and patient should discuss these data and then decide exactly what you want. You should not do whatever you want to do for the patient. Now, this was just one patient, 68-year-old female, very small build, short patient. The size of the head was just 37. We had a problem because at that size, the head you expect, the acetabular cup you expect is about 41, 42. And at that size, the cup size, you get about 22 head. Becomes very difficult to get those implants also. So here we had used cemented bipolar, used a dysplastic cemented stem. And she has so far worked well. She's 68. Now she's nearing about 75. It's working so far so good. So we are not just accepting. So these are maybe some exceptional cases where you may have to go and resort to the bipolar. Okay. Now we go to the neck femur fracture fixation failures. Case TC fracture fixed somewhere else, not fixed very well, collapsed. So what do? You can start from the other end.
Yeah, this is total hip.
You wouldn't worry about anything else?
The screw side is the stress riser. While broaching the stem, you need to be careful and not to break the trochanter. And you have to keep an option of trochanteric wiring if you do to broach it very not meticulous.
Okay, next. Any other issue would like to worry about?
Rule out infections.
Sorry?
Rule out infection.
Infection.
Have a hardware in situ.
How will you do that?
The infection parameters. And my option will be total hip replacement. And since a fracture neck of femur, my option, I'll consider dual mobility for my socket.
Dr. Mahajan, anything to add?
Ultrasound of the hip can be done prior to surgery in case you want to see the capsular thickness or any fluid which can be aspirated. Otherwise, straightforward THR without, of course, don't have to go laterally too much. Yeah.
Implant will be?
Standard uncemented hip with a Altrax and the ceramic.
Uncemented hip.
Uncemented hip, yeah.
Okay, the next one?
Cemented hip.
Uncemented THR. Vijay, you want to change that? Go for cemented?
No, uncemented.
Neck femur fracture, that means the patient has probably osteoporotic bones. And
if I don't get rotation stability with my uncemented stem, I have no hesitation in cementing the stem, but I would certainly go try an uncemented stem, is for sure.
Amar?
The take-home message I would give is first to dislocate the hip before you remove the screws. Make life easier.
Pradeep, anything different you want to add?
Uncemented and try to fill the screw holes, sometimes quite big holes. So you have the bone, you can just fill the bone.
Only thing is, this implant is easy to remove, but sometimes you've got interlocking implants which are put, and those implants need specific implant removal set. You have to be very sure that you have those implants set. Especially in India, you get multiple companies, and one screw driver will not fit into the other one. So you have to make sure which implant is there, and do you have the adequate implant to extract those during the surgery. We have to take introp, maybe, if you find any difficulty about having some granulation tissue or any worry about it, we can delay the surgery. We normally take intraoperative culture samples. And surgery-wise, it's not a very big thing. On table, you have to take a call on cemented or a non-cemented. This patient, we did non-cemented implant because it looked very stable on this thing. In a post-surgery 3-month X-ray, we realized that the trochanter at the level of the screw has just fractured off. Although the hip was very stable, we continued that with the support for the first few weeks. Patient healed completely very well. The trochanter has healed, maybe because the soft tissues were intact around the fractured trochanter. A lot of articles have been published, and they basically mention that there is a high risk of malalignment, high risk of dislocation, high risk of periprosthetic fracture, infection, all these things compared to the standard THR, but outcome is usually good. So we go to the third thing, primary prosthetic replacement in intertrochanteric fracture. Which patients with intertrochanteric fracture, we do a primary arthroplasty, surgical technique, implant choices, and intra problems. There's a patient, 86-year-old female, diabetes, hypertensive, just household ambulator, had a fall at home, domestic fall, no big injury, and that's the AP lateral X-ray. So,
Yeah. These cases, we should do a total hip. So the aim is to make them walk as early as possible, because trying to make them fit for surgery is one issue, and osteosynthesis, fracture union is a second issue. So early mobilization, 1 day of even waiting can deteriorate the medical condition. So immediate weight bearing is possible only with bipolar cemented hemiarthroplasty.
Amar?
Should be done. And here one point is you may require high offset because there's a lot of laxity in intertrochanteric.
Amar, you want to add something or you differ?
No, I mean, I think it's not unreasonable to do a primary total hip in this situation. And you know, that's what I would do. It's a more challenging reconstruction. And you know, I might even put a primary constrained liner in just because of the peritrochanteric comminution.
So you do THR, not the bipolar.
I don't know what a bipolar is.
Hemiarthro.
They are not available in USA, I think, bipolars.
I know what it is.
Okay, I'm sorry. Vijay, you want to add something?
Yeah, this combination of the lateral cortex is the key indication where we certainly will do arthroplasty. So non-cemented distal fitting stem with a bipolar. I'm not worried about dislocation because as long as you maintain the continuity of this, your low velocity injuries. We never use dual mobility in this, and we have done a large series, and dislocation is not a problem.
Yeah.
Distal fitting stem with THR.
THR?
Yeah,
Okay.
totally.
Bipolar with distal fitting stem.
Cemented stem bipolar.
Uncemented maybe as well.
Uncemented stem.
Wagner can go easily with a good flute, yeah. Maybe cemented as well, but I think the cement will have a trouble of the...
Wouldn't you be worried about the osteoporotic bone that you try to put Wagner with a
if you
good fit,
see the cortex
keep on
is-
expanding to get a good fit, and sometimes it just breaks?
No, Harish, the most complex of revisions that you do, THR revisions, you do non-cemented stems. So this is no different. Even if it's osteoporotic, etc., non-cemented stems works very well. The reason to avoid stem is the fracture. You don't want cement near your fracture.
Any different thing you want to add?
Cemented bipolar, and also I keep the Wagner type of stem. There's a calcar is broken here, so we need to build up the calcar, either calcar grafting or cement, like that. You can do that.
Okay, we did cemented bipolar. Usually we do cemented for these cases because cemented works very well. I am little apprehensive about putting non-cemented stem in these osteoporotic patients because of risk of fracture. And it is not just my apprehension. A lot of articles have been published about so-called primary prosthetic replacement in these badly damaged osteoporotic elderly people with trochanteric fractures. And they have mentioned that there are certain things, they should be either biologically old to have arthroplasty. I mean, younger patient, even if it is commutated, you should not do it. Patient with a good quality bone, again, you should try to fix it. But when a combination of these three factors are there, biologically old patient with multiple comorbidities, maybe above 80-year household ambulator, severe combination of greater trochanter, where your fixation devices will not work, and severe osteoporosis. If these three combination is there, then they are better served by primary prosthetic replacement than trying to fix them. And it is, all the literature say the same thing. And most of them say it should be a cemented stem, not a non-cemented stem if possible. The last category is intertrochanteric fracture, failed fixation. We have to convert that to THA. So this is a patient, both sides surgery was done in sequence, not at one time. And the right side is painful. The patient has pain on walking, pain, full discomfort. So how do you, it's a 62-year-old female and 2-year post-surgery, progressive pain in the right hip. Just 2 years. From the other end, can you, what will you do?
Basically, we need to rule out infection and keep the Wagner type of stem to bypass the last screw site to prevent the stress riser and fractures. Otherwise, cup site is not much anything.
Next one.
I do agree. I'll also go for a long distal fitting stem, cup side normal.
Why do you think there is infection?
There is a bit of lysis around the proximal screw.
But so is on the other side. The other side also has a lysis there. And that side is completely
Here it's a
asymptomatic.
secondary degenerative arthritis is seen there.
Yeah, that is there on the right. On the right.
The right side.
Left one has a periprosthetic osteolysis, but no pain on that side. So why do you think there is infection on the right side? It could be the similar osteolysis as you see, because maybe while healing, the implant may have become slightly
If you
loose.
see distally, there is a cortical thickening on the right side.
Okay. Unmesh, you want to add something?
Very good implant removal set. All possible things to get a difficult screw removal.
Yeah.
I think infection can be ruled out preoperatively by a blood test and ultrasound, but looks straightforward. Only thing is Wagner's stem should go beyond the fracture last screw, couple of centimeters below the last screw.
Anything you want to add?
No, nothing. Same.
Vijay?
We don't see the distal tip, but if it's a long plate, I would just cut the top of the plate and then take only the screws that comes in my way and I'd put a standard stem.
Okay. Amar?
Yeah, I agree with all those statements. And once again, I would dislocate this hip before I started taking any hardware out.
Yeah. Pradeep, anything different? Yeah. On table, there was significant doubtful looking tissues when we removed the implant. So we curated everything else, sent it for culture. I was not very comfortable putting immediate implant at point of time. And it did grow Enterovector cloacae in that area. So we had to give IV antibiotic and wait for about 3 months after course of 6 weeks of antibiotic was over. And then we did a reasonably standard non-cemented THR with a ceramic on poly composition. So it's very important that whenever there is a previous implant done at any other place, but not you, you have to be suspicious about infection. If you have any doubt on table, don't do hip replacement surgery at that point of time. Wait, just remove the implant, do the deep cultures, and do it at a later stage. Now, just one last case, 78-year-old female, fall at home, IT fracture, treated with ORIF, and it didn't work, it failed.
Let's add one point. I saw you put was that a prophylactic wire or was it a?
Yeah, it was a prophylactic wire to make sure, because when you broach, this was a coral implant, it's a square shaped thing. And in the Indian patient, if you use that, sometime if you are a little aggressive, it can create a crack in the proximal part.
Well, and especially in this setting, right? This is, in my opinion, the wrong setting to do a broach-only stem, right? So I would use a Riemann broach or even a Riemann mill type system like the SROM, where you can really prepare the bone with milling and reaming techniques, and so you don't risk the fracture in that sense.
There is a bone formation along the implant track, and that can lead your implant astray, and it may give a malpositioning and maybe a crack. Vijay, you want to add something?
The important message that the broach only, like the coral, will lead to a lot of problems, although you may get away. And when you don't get good proximal fixation, you may end up with a DOR-A type failure in the medium term. So I would think that the choice of this stem is not very ideal for this situation, except this situation.
Yeah. Just the last case, Parag, I'll just take 5 more minutes. Sorry. Yeah. 78-year-old female, fall at home, first surgery, failed implant. Then somebody did second surgery, obliques, 135-degree DHS, and that failed. And now the question is, what do you do? These are the cases which are not uncommon in India. We do see them a lot, and they come to you as a replacement. Pradeep.
Once you rule out infection, I think ETO is the best option. Just remove all the screw and put a Wagner and THR.
Implant?
A Wagner and THR.
Wagner, okay. Amar, anything else?
Yeah, I mean, they have broken screw sets where you have trephines, you trephine over the screws. You don't need to do an ETO. It's a little cumbersome, but you can get them all out and then do a Wagner type stem.
Pradeep, you want to add anything? Nothing? Okay.
A trochanteric plate. You might require a trochanteric plate for that part.
We use the implant when you take so many screws out with the core reamer, then sometimes you create a crack fractures, and the proximal fragment can just get into multiple fractures. So we had to use the distally fixing. Now it was very difficult because osteoporotic bone was not allowing us to get a good distal fixation. So we use a long stem. This is a C stem, long stem cemented implant having a distal fixation. 1 year post surgery, patient had reasonably good function. a lot of articles have come about these post-fixation failure and conversion to THR. The common message is, each case is different. We must plan for removal of implant, get the proper equipments, assess the bone loss which will happen, effect of the previous surgery, soft tissue scarring to be considered. Low-grade infection is always a problem. You have to be careful about it. You must be able to build the bone and build the lost bone. And orientation of implant and soft tissue balance becomes difficult because you don't have a good bony morphology to start with. Thank you very much.